Good afternoon, everyone. John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn. Today, we are very excited to hear about carpal tunnel syndrome, death, taxes, and carpal tunnel syndrome. Next slide, please, Waji. And I'm just going to give a few introductory slides, as I usually do. We have one more lecture left in our series. We will take our typical summer hiatus. And as summertime is a good time to go ahead and check out some talks that you have missed. Next week, we are ending our series on cataract and corneal surgeries. Dr. Coe will be here to discuss this from a primary care point of view. All these talks are up on our intranet, Newton, as well as also published up on YouTube. If you're having trouble finding something, just go ahead and search Newton-Wellesley Medical Group Lunch and Learn in your search bar. Next slide, please. Two things we want to promote today. One is our learning to treat opioid addiction and managing substance abuse disorders. We have a seminar coming up on Wednesday, June 22nd. It's a half-day seminar. Registration deadline is tomorrow. So I wanted to get that out there once more. This is a great course for anyone who's taken it, even if you're not interested in prescribing Suboxone or even managing patients who take Suboxone. This is a great refresher course. Also does satisfy requirements that you'll need for re-registering with the department for medicine in the state of Massachusetts. Next slide. And then we've also made available free on-site and virtual fitness training for individuals or groups at the Shipley Fitness Center. This part comes from our wellness grant, our physician wellness grant, and we have dollars left over. And Daniel Destin and his team are very excited to set this up for you or a group of folks. This is free, this virtual fitness training. So please take advantage of it. This is definitely, as they say, while supplies last. Also, we have been promoting this all year. The Shipley Fitness Center is actually free badge access for all employees, and that's been extended through August 31st. So if you have not been to Shipley, come join us for one workout. You'll fall in love there. The price is right. It's right on campus. Hours are extensive. They're open 7 days a week, and this is a great way to kind of get used to the program and to the fitness center with some online coaching and physical training. Next slide, please. And I'll leave it to you, Waji. Thank you for being here. And any questions or anything, you can post in the chat room. We'll get to them at the end.
All right, thank you. Thank you very much, Dr. Snyder. Can you hear me okay?
Yes, we can.
All right, great. Well, thanks everyone for joining us today. My name is Wajdi Kanj. I'm a hand and upper extremity surgeon here at Newton-Wellesley Hospital. Today, I'll be talking about a subject that's near and dear to me. That is carpal tunnel syndrome. Not so much the death and taxes part, but we can talk about that if we have some time at the end. And so again, this is me. I've been here in Newton-Wellesley for a few years now. I'm sorry if I haven't gotten to meet a lot of you, but we have offices here in the White Building, suites 341 and 43. We also have an office down the street in Wellesley Hills on Washington Street. Feel free to call us anytime, tell us how you're doing, send us patients, chat. And then we also have a website, which is pretty good, nwoa.com. I have a whole bunch of partners. We treat everything from the neck down to the ankle and the feet. We do general orthopedics, hip and knee arthroplasty, sports medicine, including shoulder and shoulder replacements. We also have spine surgery and traumatologists. And then here's me and three of my buddies. We do hand and upper extremity surgery. Shout out to Evan Schumer, number 2 here. He recently retired. But I don't have the heart to take him off of this slide. But yeah, we do everything, and we like to get patients in same day or next day for appointments, try to offload the emergency room and urgent care centers as much as possible. We have x-ray in our office. We can do casts and splinting. So definitely give us a call for any of your orthopedic needs. I have no relevant disclosures to the topic, but I do love treating carpal tunnel syndrome, and hopefully I can share some of that enthusiasm with you guys today and yeah, make this a little bit of a more exciting topic for you. Today, I'll start with some anatomy and pathophysiology. Some of this may be redundant, or if you're a pro at this, you can just kind of snooze a little bit. Then we'll talk about some patient presentation, some of the things to look for in an exam, and then some of the diagnostic tools that we have at our disposal that we can use to supplement our exam. And finally, I'll round it off with some treatment. About 250 years ago, Benjamin Franklin has been quoted to say, "In this world, nothing is certain except for death, taxes, and carpal tunnel syndrome." He was a smart boy, that Benji. So let's talk about some anatomy and pathophysiology. Again, this might be redundant, but I think it's a lot of fun to kind of teach this to patients. It gives them a better understanding of what's going on, and hopefully you can take this skill with you as well. So the carpal tunnel is a confined space within the hand, starts roughly at the level of the wrist crease and extends about 2 or 3 centimeters distal into the palm of the hand. The floor and the walls of that tunnel are made up of carpal bones, and then the roof is made up of a ligament that spans those bones. Now, ligament is called the transverse carpal ligament. We also refer to it as a flexor retinaculum sometimes. Within that tunnel, on a cross section on your right side here, runs the median nerve, the yellow structure here, as well as 9 individual flexor tendons. And so what can happen, typically the pathophysiology, is that as the flexor tendons become inflamed, seen here is this little pink lining getting a little bit thicker, this effectively will decrease the available volume for the median nerve. And so then what will happen is that nerve gets compressed and we cause this compression neuropathy. The patients can have symptoms directly related to the flexor tenosynovitis or the inflamed tendons. Typically that would be stiffness with finger flexion or wrist flexion, but really it's the symptoms of the median nerve compression that are what will lead the patient to present to our office for evaluation. There's been a number of risk factors and etiological factors that have been looked at and described. Metabolically, this is more common in patients with diabetes, certain types of thyroid disorder, and obesity as well. And a lot of times managing those metabolic conditions can improve the symptoms. It might not cure the problem, but it can definitely improve them. Historically, a lot more emphasis was put on occupational risk factors. One of the common misconceptions is that secretaries or people that are spending their entire day working and typing can cause this. It hasn't actually borne out in the literature that it can cause it. It can exacerbate those symptoms for sure. And we often will make some ergonomic adjustments at work to help with these symptoms. Certain autoimmune conditions can also put the patient at risk. I see a lot of patients with rheumatoid arthritis that will have concomitant carpal tunnel syndrome, and that's usually from the increased inflammation around the flexor tendons. Young, otherwise healthy women who are pregnant or postpartum if they're breastfeeding, that can cause also a similar situation where the tendon sheaths and tendon linings will be inflamed, and that can cause carpal tunnel syndrome. And then a little bit of a different beast is the acute carpal tunnel syndrome, which is associated with trauma. Commonly, we'll see that with wrist fractures, fracture of the distal radius, and also we frequently will see it in settings of forearm compartment syndrome. That kind of carpal tunnel syndrome is treated a little bit differently than the chronic carpal tunnel syndrome, and usually will require relatively urgent surgical management. The clinical presentation is fairly typical. There are some variabilities, but there are some pretty standard complaints that we'll see. So patients will often early in the disease course will have complaints of pain, and that pain can be an electrical or a stabbing pain. That's the same pain that you would get in your hand if you hit the medial aspect of your elbow and you strike your ulnar nerve, or the funny bone pain. That's that same kind of tingling pain. Patients will have numbness and they'll say it feels like I'm wearing a glove, or I don't quite have the same tactile feedback. That paresthesia, that would also be the pins and needles, a static or a buzzing sensation. As the disease becomes more advanced, they can get some weakness, and that can be subjective or objective weakness. They can have difficulty with grip strength or fine pinch motion. The loss of dexterity is a fun one that I like, kind of preempting it for the patient and say, oh, do you have problems with doing your button or picking up coins? And they say, oh my gosh, doctor, you're so smart. Absolutely. How'd you know that? And that's a sense of a fault in the biofeedback loop. And then finally, the almost pathognomonic finding is a nocturnal awakening. So from deep sleep, they'll wake up, the hand will be pins and needlesy, painful, and they'll shake their hand or let it hang off the edge of the bed or walk around, and that'll relieve those symptoms. That's almost pathognomonic for carpal tunnel syndrome. In terms of examination, what I look for on observation, visually, you can sometimes see thenar atrophy, and that's demonstrated here in this image on the left. You'll see a little bit of almost like a sulcus in the palm of the hand there. The typical sensory pattern for a median nerve is the radial 3.5 digits of the hand. This diagram is a little bit wrong in that it shows a lot more of the dorsum of the hand. Typically, it's the entirety of the palmar surface of these 3.5 digits, and then just about at the DIP joint, or at this first knuckle to the fingertip, will also be innervated by the median nerve. Sometimes, occasionally, the patient will come in and say, yes, my thumb, index, middle, and half of my ring finger are numb. And that's like a home run when that happens. You say, perfect, you read the textbook. Most of the time, that's not the case. They'll come in with a few of the fingers, maybe the index and middle, maybe the middle three, sometimes all five. This is classically the median distribution, but it doesn't have to be that way for the carpal tunnel syndrome. There's a number of provocative maneuvers as well that we'll use, and these should be relatively familiar to you. Historically, a lot more value on the sensitivity and specificity was given. More recent studies have shown these numbers to be a little bit more modest. So in terms of increasing sensitivity and decreasing specificity, the Tinel sign, which is performed by providing a percussion maneuver to the course of the median nerve. Typically, I'll do that in two spots. One is directly over the carpal tunnel in the palm. The second will be at the distal forearm, just proximal to the carpal tunnel. Now that's not so sensitive, but it is a little bit more specific. Phelan's test is a flexion of the wrist. So prolonged flexion of the wrist can reproduce those symptoms. Durkin's test involves compression over the carpal tunnel. And then what I typically do is I refer to it as a Durkin's test, where I combine a Phelan's test and a Durkin's test. That has a much greater sensitivity, but also much less specificity. Probably most people, if you actually did that to them, within 20 or 30 seconds, they will get some numbness, tingling, or paresthesias in the median distribution. But if it doesn't do it, then I think it's unlikely that they actually have a true carpal tunnel syndrome, or it's quite mild. Really, I should emphasize that carpal tunnel syndrome is a clinical diagnosis, and mostly it's going to be based on your exam and the patient's history that we make this diagnosis and we treat the diagnosis. With that said, there are a few extra tools that are available to us. The TTS-6 is one of the most studied clinical tools, and it's basically a sort of questionnaire plus physical exam findings that goes through these 6 features. And if the patient is positive for 3 or more of them, there's an 80% probability that they truly do have carpal tunnel. Some of these are pretty typical. The one thing that we not often do is a 2-point discrimination. You can do that. It doesn't take much time. But usually a patient with carpal tunnel will have at least 3 of the other 5. And so rarely am I doing a 2-point discrimination in the office, but it is relatively easy to do. Historically, and even still today, electrodiagnostic studies remain pretty much a mainstay in the diagnostic tools for carpal tunnel syndrome. It's important to note that there's no real contraindications to electrical diagnostic studies. So if you have a patient with suspected carpal tunnel syndrome, there's nothing at all wrong with sending them for a nerve conduction study and an EMG. With that said, I don't always get them, and it's a little bit debatable on whether or not it is important to every time get electrical diagnostic studies before treating carpal tunnel syndrome. So I'll quickly go through a little bit of the science behind it. There's 2 components. The first is a nerve conduction study. The nerve conduction study really is a function or measures a function of the nerve itself. So there's 3 kind of features. One is the latency. What that is a measure of the delay in the signal, or the time it takes that signal to reach the probe to the detector. These are standardized values that are specific to the lab, and they're what we use most commonly to quantify or qualify the level of nerve compression. So a sensory latency of greater than 3.2 milliseconds is abnormal. Motor latency is more than 4.3 milliseconds. You don't need to memorize those numbers by any means, and those numbers will be unique to the lab that it's being done at. Usually you just look at the report, and numbers that are bold are abnormal. The velocity is simply the distance divided by the latency, less often used for carpal tunnel. More often we use that for cubital tunnel at the elbow. And then finally, the amplitude is directly proportional to how many motor units are being depolarized when that nerve is stimulated. So typically with more chronic conditions, the motor units will start to drop off, and that amplitude can diminish. EMG, on the other hand, measures a function of the individual muscle fibers and motor units versus the nerve. So this can be used to evaluate the chronicity of a disorder and to identify any evidence of reinnervation of those muscle groups. We don't always get the EMG, but the nerve conduction study should always be done for carpal tunnel. There's a couple of abnormal things. Insertional activity, when you insert the needle into the muscle, there should be a relatively predictable pattern of muscle activity. Contraction activity would be when the physiatrist or the physiologist or the neurologist asks the patient to contract that muscle. Also, there should be a relatively predictable pattern of motor unit activity. And then spontaneous activity is just electrical activity in the muscle that happens at baseline with no stimulation. So any of these can be abnormal and can be indicative of underlying pathology. Beyond compression neuropathies like carpal tunnel, this can also be helpful for intrinsic neuropathies or things like hereditary motor and sensory neuropathy, things like that. They will have abnormalities on EMGs. Ultrasound is becoming a more commonly used modality in both diagnosis as well as treatment for carpal tunnel. So typically, some of the findings on an ultrasound will be proximal nerve swelling. So just proximal to the actual transverse carpal ligament, the nerve will get a little bit more swollen. And then on a longitudinal view seen here, you can actually see where the nerve is compressed. Grossly, sometimes in surgery, we will see this and we call it an hourglass compression because the waist of that nerve will be compressed and the swelling will go both proximal and distal. We can measure the cross-sectional area on that nerve. And if that cross-sectional area proximal to the carpal tunnel is too large, typically greater than 15 millimeters squared, that's considered abnormal. The nice thing about ultrasound is you have both limbs to compare to. Again, no real contraindications, but we have a couple of them in our office. You can do it quick and easy. And more studies are now showing that it can be just as helpful as electrical diagnostic studies in terms of diagnosis. So now let's talk about treatment. So my algorithm for treatment of carpal tunnel is pretty simple. The majority of patients, I'll typically start with nocturnal splinting, so just wearing a splint at nighttime. And if their symptoms are mild or it's early in the disease, that can sometimes continue indefinitely, so long as it's controlling their symptoms. Occasionally, there will be a role for a cortisone or a steroid injection in the office, and I'll tell you about that in a minute. And then ultimately, a majority of patients will find their way to surgery. So one of the pathophysiologic features of carpal tunnel syndrome is that when we go to bed at night, our extremities get a little bit more swollen, and we all pretend that we're still tucked away in mom's womb, and we will flex our wrists and our elbows. And what that does when you flex the wrist, it increases the pressure from the flexor tendons onto the nerve, onto the transverse carpal ligament. And so by keeping your wrist straight at night, that can take the pressure off of that nerve and put it in a more neutral position. So for early disease or mild symptoms, or the patient who says, "Doc, it really wakes me up at night. During the day, it's not as bad," I think nocturnal splinting can really be helpful. It might not be a great long-term solution, but it can definitely get you months or sometimes even years of relief. It has been shown to be better than making ergonomic adjustments, but usually I'm finding both of those to be helpful early in the disease. Now, steroid injections do have a role. I probably use them less than the average hand surgeon for carpal tunnel syndrome. I have some diagnostic or prognostic indicators and then some therapeutic. From a diagnostic point of view, if the patient has a pretty straightforward, typical run-of-the-mill, boring carpal tunnel syndrome, it's rare that I'll recommend a steroid injection unless they say, "Doc, I don't have time to do surgery right now, but I can do it in 3 or 4 months, but I have to get through this next month, I'm moving, etc." Sure, we can do a single steroid injection to get you through these next few months, as long as you don't fall off the face of the planet and then come back in 3 years with worse disease. And that's my biggest fear, is that you can be making them feeling better while the disease in the background progresses. So there's that indication. If I'm unclear of the diagnosis, or they have something like a concomitant cervical radiculopathy or some other compression or brachial plexopathy, something else, I'm not sure how much of the symptoms are coming from the carpal tunnel or not, I will often use a steroid injection in that situation to figure out what percentage or what ratio of their symptoms are coming from the carpal tunnel syndrome. And then if the patient has really long-standing disease and I'm trying to get a sense of how much of their symptoms will improve after surgery, or will their symptoms improve after surgery, I can use it in that situation as well. Therapeutically, the most common patient kind of demographic that I use it as a true therapeutic treatment is for pregnant women or breastfeeding women. In those patients, the thought is once they're out of their pregnancy, once they're in the postpartum or they're done breastfeeding and that risk factor has diminished, I would hope and expect that their symptoms should improve. So to get them to that point, a steroid injection is a great option, and it's safe during both pregnancy and breastfeeding. Occasionally, I will have a woman who a steroid injection is not enough, and we have to do an operation. But obviously, we try really hard to avoid that as much as we can, especially during pregnancy and in the immediate postpartum period as well. Finally, for elderly patients who have very advanced or severe or chronic disease and would not otherwise be a great candidate for a procedure, we will often use steroid injections for them almost palliatively just to get them through the next 3 or 6 months. And there are a number of other alternative treatment options. I will admit I don't use any of these. There's not great evidence really for any of these. Historically, occupational and physical therapy have been utilized for carpal tunnel syndrome, and there is some studies that show that can be beneficial. I don't really find them to be that effective as long-term solutions, and most of my patients don't experience much relief from this. Some practitioners also utilizing ultrasound therapy, something called magnetic wristbands or magnetic therapy. And I even found this pneumatic device called the C-Track, which is designed to stretch that transverse carpal ligament slowly over several weeks. To use this for 15 minutes a day. Who knows, maybe there's some short-term benefit to it, or if the patient doesn't have a chronic compression, we just need to get them through some time, maybe there's a role for this, any of these, but it's really not very well studied. So I'm a surgeon, so I have to talk about surgery. There are 2 widely accepted techniques that we can use to release or decompress the carpal tunnel. Traditionally, there's an open technique, and that is done through making a small incision in the palm, such as this picture, and literally getting down to that ligament, cutting that ligament with a knife, looking at the nerve underneath, spreading it, taking the pressure off, and then closing that wound. And then over the past couple of decades, endoscopic carpal tunnel release has now become widely accepted. Still to date, the majority of carpal tunnel decompressions done in this country are still performed as an open or a mini open procedure. Only about 20% of those are done endoscopically. Here in this area, specifically the greater Boston area, endoscopic is probably as popular as open, if not more popular than open. And especially at this hospital, I'm pretty sure all the hand surgeons now prefer endoscopic technique. The debate goes on and on regarding the preferred treatment choice. This has been looked at over and over, and I don't really have the time to go into details on that today. But the main advantage of an open carpal tunnel release is that from a healthcare cost, it is less expensive. It requires less training, and the equipment that are needed for that are much cheaper. Meanwhile, the endoscopic technique is more favorable for the patient in that it's a much faster and easier recovery. Proponents of each of the options will tell you that their technique is safer. There are different risks to each of the surgeries, but in general, this is one of the safest operations that we do with very, very low complication rates. The most important thing that I'll emphasize to all of my patients is that at 6 weeks, typically, regardless of which technique they use, their clinical outcome will be largely identical, other than the location of their surgical scar. So this is just a 40-second video here showing how I do an endoscopic carpal tunnel release. This is a view through the endoscope inside the carpal tunnel. So deep within this clear cannula is the median nerve over here and the flexor tendons over here. And then the roof of that cannula, what we're looking at there, is some of the forearm fat, and then you'll see the transverse carpal ligament. Within this device, I have a special little blade and knife that gets projected up and then is used to cut the ligament. And this is basically the entire length of the operation right here, what you're about to watch. And then once I'm done, the muscle fibers here that you're seeing are some of the thenar or hypothenar fat. Let me just get a little bit more right there. Perfect. This patient feels so much better now. And now I'm showing the 2 ends of the leaflets, and that carpal tunnel is now very happy and decompressed. This is my post-operative protocol, and I mention it here because a lot of patients come and they say, oh my God, I don't want to have surgery. I can't be out of work for 4 or 6 weeks, doc. I say, that's okay. You're not going to be. It's a small incision, about 1 centimeter, sometimes less. I use dissolvable sutures with a little bit of Dermabond on top. It's a very low profile, soft, very uninhibitive dressing. I let them use their hand for light activities immediately after surgery. They can brush their teeth, feed themselves, type, drive the next day, no problem. They take off their dressing after 2 days, then they can get their incision wet, washing their hands, showering. I let them get back to heavy lifting about 1 or 2 weeks post-op. I typically only see them back 1 time in the office, about 10 days, make sure their wound is healing, make sure their symptoms are getting better, and then I let them back into the wild. Very rarely do I have any patients need hand therapy. I maybe have 1 patient a year that needs hand therapy, and usually it's for some level of increased stiffness or something like that. And I let most patients get back to work in about 2 days if they're low demand work, or 10 days if it's manual labor after I see them back in the office. So that's it. Again, my name is Wajdi Kans. I'm a hand and upper extremity surgeon here at Newton-Wellesley. I just gave you a riveting talk on carpal tunnel syndrome. Be happy to have you come by anytime. Call me, email, message. Happy to answer any of your questions as well. So thank you very much. Here's a happy median nerve.
Thanks so much. I don't know if people could see the nerve dancing there. That's great. And any quick questions before we let Dr. Kans get back to his office practice? Thanks so much for coming out and showing us. That video was pretty cool. It doesn't look like a very a long surgery. How long do you tell your patients it's going to be, you know, from the point that they enter the OR till that? And I'm assuming it's all under local kind of therapy. They're up and talking to you the whole time. Is that correct?
So it can be done with local only. Typically, we'll do a little bit of sedation. The procedure itself, start to finish, takes me about 5 or 6 minutes to do. That's from making incision to closing the wound and having, you know, dressing is on, usually about 7 minutes. They're in the operating room for about 15 minutes. You know, and they're in the surgical suite for maybe about an hour and a half total. So it's pretty quick. You can, you know, have half a day of work before or after if you want. But they do typically get a little bit of sedation just to keep them comfortable. As an aside, one thing that Nikki Leung and I are working on is introducing ultrasound guided carpal tunnel release now, and that would be something that can be done with local only anesthetic even in the office. And that's something that we've been working on for a few months, and we're hoping to introduce into our practice in the next couple of months as well. And that's an even quicker and easier recovery than this, if you can believe it.
That's amazing. Before I let you go, I had one other quick question. So as primary care, we get a lot of people coming in with those devices you kind of showed or things they saw that can help cure. Any role for a PT or any kind of other therapy prior to folks if injections don't work and they don't want to do the surgery?
There's no harm in it. Anecdotally, some patients will find maybe some benefit in therapy. I haven't found it to be a good long-term solution. If they really want to avoid an operation, I think there's nothing wrong with it. My one hesitation is, again, the longer you wait on this disorder, the chance of the nerve becoming irreversible damage does go up. So the most predictable way to treat it would be early with a decompression to let it, you know, again, free the nerve. So if they're willing to try therapy for a few weeks or even a couple of months, knowing that it may or may not provide any relief, I'm fine with that, so long as they don't do it indefinitely and then it doesn't delay their treatment any longer.
Excellent. Thanks very much. Again, thanks again for being here and for doing that. We'll welcome everyone back for our last talk in the series next week. Hope everyone has a grand weekend, and let's hope the Celts can pull out 2 in a row. And don't sleep on the Sox. They're making a run on it if you haven't been watching. And we'll see you all next week. Thanks. Take it easy. Bye.
Thank you.